You want me to go first?
Yes.
She's coming in.
Oh, she's coming.
Okay, so this lecture is about the definition of relapse and when we usually start treatment at relapse, because after this there are about a few presentations talking about what medications to choose for relapse, and then there are some focus points on proteasome inhibitors and then immunotherapy and cell therapy and so on. So this is really just about what we understand for the definition of relapse and when we usually do initiate treatment. As you know, and I've explained earlier, monoclonal gammopathy of unknown significance and smoldering myeloma usually precede multiple myeloma. And usually when the patient does have myeloma that requires treatment, and we've discussed today what are the definitions for that and what are the criteria for that, always using common sense, then we initiate treatment. And unfortunately, after treatment, multiple myeloma usually follows this relapsing and remission pattern that we see here. And usually the relapses each time last or are more difficult to treat, and sometimes also the remission phases last a little bit less. And when the myeloma is then refractory, the prognosis for these patients is usually very poor. You may have seen this slide before. This is just a treatment slide to see how far we've come with treatment for multiple myeloma. It really has only been about 10-15 years since we started using proteasome inhibitors, which was a major breakthrough in the treatment for myeloma. You can see also here the rates of very good partial response throughout the different treatments as they have been reported in clinical trials. As I mentioned, the duration of the response decreases as the number of treatments received increases, which is also linked to poor prognosis. So how do we define clinical relapse? So there are very clear definitions by the International Myeloma Working Group criteria about this. So usually we need, in patients that have an M protein in the blood, an absolute increase of 0.5 grams per deciliter, which we usually need all these assessments that we're talking about. We need them in 2 different time points, so they have to be confirmed. We also need an absolute increase if the patient has Benz-Jones. We can use the urine M protein, or you can use also the kappa and lambda light chain levels. We're using the M protein. There has to be an absolute increase of 200 milligrams of Benz-Jones in 24 hours. If we're using the difference in the kappa and lambda levels, or lambda and kappa, depending on what the patient's protein is, then the ratio between the abnormal and the absolute change has to be more than 10 milligrams per deciliter. If the patient does not have measurable M protein levels and we're looking at just bone marrow plasma cells, the increase has to be at least of 10%. The patient may also have just extramedullary myeloma. If they have new bone or soft tissue lesions, that's also an indication for relapse. And if they have hypercalcemia that is due to the myeloma, then we would also consider this an indication for treatment and relapse. The definition of refractory myeloma is a disease that is not responsive while on therapy or that progresses within 60 days of the last therapy. And this is what's used as refractory when we talk about refractory myeloma, especially in clinical trials. We also can divide the relapse between asymptomatic and symptomatic. So biochemical relapse, or an early biochemical relapse, is a term we use for patients who have an increase in their myeloma paraprotein or light chains, but do not have any symptoms or organ compromise. These patients oftentimes can be observed closely without treatment. However, early intervention may also be warranted, and we'll see in what situations we may consider to intervene in these patients. Symptomatic relapse occurs in patients that have new symptoms or organ compromise that can be attributing to the underlying relapsed myeloma. And in these patients, treatment should be instituted promptly. The goal of this treatment is to relieve the disease symptoms. So what are the indications for treatment at relapse? For clinical or symptomatic relapse, this is very similar to what we have for diagnosis for the newly diagnosed myeloma. So if the patient has new soft tissue plasmacytomas or bone lesions, if there is an increase in the size of existing plasmacytomas or lesions, if there is hypercalcemia, if there is anemia to a certain degree, if there is a rise in serum creatinine that is due to the myeloma, or if there is hyperviscosity. When there is significant biochemical or asymptomatic relapse in patients without a clinical relapse, we may also consider the initiation of therapy. For example, if there is a very consistent increase in the M component in the blood or in the urine. For example, here there's a measure that if it's more than 0.5 grams per deciliter, separated by at least 1 or 2 months, if this is doubling very quickly, then this could be a sign that we need to start treatment because this patient may develop symptomatic myeloma from relapse in the near future. Also, if there are 2 consecutive measurements, if the absolute levels of the M protein go by 1 gram per deciliter or 10 grams per liter, if there's an increase in the M protein by 500 milligrams in 24 hours, or if there is an increase of 25% of the light chains or more than 20 milligrams per deciliter with an abnormal ratio. So this could be all indications that we need to start treatment. So these are some measures that you can use in your patients in the clinic. There are also some treatment guidelines that have been published for the choice of treatment at relapse. And I think that our later speakers might go into this with more detail, but I'm just going to mention a few things that are a little bit of common sense. So the first thing is, has the patient had a stem cell transplant? So if they had not had a stem cell transplant, you could treat and transplant them. And then you also have to consider what has been, if they have had a transplant, what has been the first induction treatment that they got before the transplant. And then you also consider, have they gotten any novel agent? Usually that's bortezomib, lenalidomide, carfilzomib, and so on. If they have never gotten a frontline novel agent, then usually they recommend bortezomib or IMiD-based therapies. If they have had bortezomib and IMiD-based therapies, then if there has been a very long remission, then you could use the same regimen. So if the patient got a VTD and then a transplant and they had a period of remission of 5 years, you could give again VTD or VRD or CyBorD, whatever you gave at that time. Especially if there's no toxicity, so they don't have any pre-existing neuropathy for bortezomib, they don't have any heart disease for carfilzomib, etc. You could also switch drugs. Sometimes a lot of patients, or doctors, what they do is they just switch to a different class. So if you had an IMiD-based, you go to a bortezomib-based. If you had a bortezomib-based, you go to an IMiD-based. And then if you had both, then we try alkylators, or we do clinical trials, or we try newer classes of proteasome inhibitors and IMiD, such as carfilzomib and pomalidomide, and so on. Okay, any questions?
Thank you very much. This topic is open for question and comment. Concerning the regimen that for the relapse multiple myeloma, in case of the patient who got the lenalidomide maintenance, do you think that the regimen will include lenalidomide or not? Is it?
You can, because so lenalidomide maintenance, the highest dose that I have given is 15 milligrams daily. And that's the highest dose that they've given on clinical trials that I know of on long-term maintenance. Mm-hmm. So I usually don't increase just the dose of lenalidomide and add dexamethasone, but it also depends on patient preference. So if you talk to the patient and the patient says, I cannot get any infusions, or I don't want to add any more tablets, then one option would be you could give them a bigger dose of lenalidomide with dexamethasone. However, if the patient is willing and able to add medications, then you can add carfilzomib and give carfilzomib, Revlimid, and dexamethasone. You can give carfilzomib, pomalidomide, dexamethasone. You can give antibodies with the lenalidomide and the dexamethasone. That's in our clinic. You could add bortezomib, so if the patient has had bortezomib before and has tolerated it well, you could just add that. You could switch to a completely different regimen, but you can most certainly, still use lenalidomide after maintenance. And even if you just increase the dose and give dexamethasone, that works. I don't think that's the best approach. I think that the best approach is to give a triple-line therapy if the patient can take it and is willing to take it. But
Any question? If no question, thank you very much.
thanks.